Hello, I'm David Gonzalez. Over the coming days or weeks, you may have the opportunity to work with the SimMan, either as part of your clinical training, in a certification course, or as a participant in a research study. To make your experience more meaningful and enjoyable, I've prepared this short video to provide some background information on the SimMan and a brief overview of its features. I also want to focus on several technical details that will help to make your upcoming experience with SimMan more valuable.
SimMan is Laerdal's full-size universal patient simulator. It is one of only 2 commercially available patient simulators on the market today and is characterized as a mid-fidelity simulator. This means that it has fewer lifelike features than does a much more expensive high-fidelity simulator. Another important difference is that SimMan uses special computer-controlled physiological sensors and monitors, whereas a high-fidelity simulator can use off-the-shelf clinical monitoring equipment. While the SimMan is able to sense activity such as chest compressions, pulse checking, ventilation, and defibrillation, he has only a limited capacity to automatically respond to these stimuli. Instead, an operator sitting at the console controls the physiologic changes seen in response to these inputs. SimMan can be programmed to respond appropriately without operator intervention, but the range and scope of its response is limited. SimMan has a remarkable set of features. He has radial pulses, brachial pulses, femoral pulses, and carotid pulses. He has breath sounds, bowel sounds, heart sounds, Korotkoff sounds, and vocal sounds. His airway is quite sophisticated and includes the ability to emulate trismus, decrease cervical range of motion, tongue edema, pharyngeal edema, and laryngospasm. His tracheobronchial tree is anatomically accurate to allow for endobronchial and realistic fiber optic intubation and cricothyrotomy. The lung's compliance can be altered unilaterally or bilaterally, develop unilateral or bilateral pneumothoraces, and can exhale carbon dioxide. The stomach can be distended either from mask ventilation or esophageal intubation. SimMan is capable of accepting a 360 joule defibrillation and can automatically change EKG rhythm in response. Over 2,500 EKG rhythms are available. SimMan can also be paced externally. SimMan can be configured with male or female external genitalia and can be catheterized with the return of liquid stored in a bladder. Every action of the simulator and the response of the trainee are automatically stored in an event log. Finally, SimMan includes sophisticated software controls that allow the programming of physiologic vital sign trends and the creation of longer, more complex scenarios.
There are 5 areas that require special attention: palpating pulses, auscultating blood pressure, auscultating heart sounds and lung sounds, starting IVs, and delivering electrical shocks to the mannequin.
SimMan has a left radial and a left brachial pulse. Note that adjacent to the brachial pulse is a circular area that is used for auscultating blood pressure, not palpating pulses. SimMan also has bilateral femoral and carotid pulses. Note that there are no pulses in the right arm or the lower extremities. The radial, brachial, and femoral pulses are mechanically actuated. These 3 pulses are present at all times, but can easily be obliterated. A delicate touch is sufficient to palpate them. In contrast, the carotid pulses are pneumatically actuated and have an entirely different feel. These pulses are activated only when palpated. As seen in the phantom view, the carotid pulses are actuated when a switch under each artery is depressed. They require a more deliberate and aggressive approach to actuate, since not only must the switch be depressed, but there are 2 layers of skin lying above the carotid arteries as well. 5 seconds after removing the palpating finger, the carotid pulses will disappear. The pulse strength will vary in response to falling systemic blood pressure and can be either normal, weak, or absent. Radial and brachial pulses disappear first, then femoral pulses, and finally the carotid pulses. The carotid pulses can be palpated during chest compression. Underneath the circular area in the left antecubital fossa is a loudspeaker that provides carot cough sounds. Although it is a common mistake, pulses cannot be palpated here. Instead, place the stethoscope firmly here and proceed to measure a manual blood pressure as you normally would. Although you won't see needle oscillations, you'll be able to hear the carot cough sounds as you slowly lower the cuff pressure. The beat-to-beat sounds will first be heard at the systolic blood pressure and will persist as cuff pressure decreases. The diastolic pressure is signaled by the loss of the auscultated sounds. Sounds emanate from the SimMan via small loudspeakers. These are distributed selectively over the anterior and lateral chest to provide breath sounds. When attempting to hear breath sounds, such as when testing for the correct placement of an endotracheal tube, it is necessary to place the stethoscope in the proximity of a speaker. Breath sounds are generally transmitted throughout the chest cavity, but can sound muffled when stethoscope placement is incorrect. Similarly, heart sounds must be auscultated over the left anterior chest, and they do not radiate. SimMan's right arm is reserved for starting IVs. IVs can be placed in the dorsum of the right hand, the forearm, or the antecubital fossa. There are no other sites for IV cannulation where actual fluids can be administered, although it is possible to place an IV under a fold of SimMan skin to simulate an IV placement. Such a strategy might be used in a simulation to emulate placement of a central venous or pulmonary artery catheter. Do not infuse liquids into a neckline. The SimMan is capable of accepting up to 360 joules of actual electrical energy during defibrillation. For this reason, real defibrillators are used during simulations. Please be sure to observe standard safety precautions during the defibrillation. SimMan is also capable of being paced externally, and the same cautions apply. SimMan has 2 sets of connectors on his chest. They are different, and it is not possible to inadvertently interchange them. The first set of connectors is for EKG monitoring, and either a 3-lead or 4-lead EKG can be monitored. 2 additional leads on the chest are for the defibrillator. They can be connected in either order. Your experience will prove to be most valuable if you treat SimMan as a real patient. Thus, when participating in simulations, you should, to the greatest extent possible, go through the motions of providing actual clinical care.